junior speaker, Dr. Nasiba Maqrashi. She is a very dedicated medical resident at the Oman Medical Association, OMSB resident, and she is have interest in research and patient care. She completed her MD degree from the National University, Sultanate of Oman. And during her academic journey, she received honor to be involved in many research projects focusing like on alcoholic withdrawal syndrome management. And also she authored publications on diverse medical topics and activity. And she's contributing also to community service activity. And she's eager to continue making meaningful contribution to the medicine. And today she will present topic review about the monoclonal gammopathy of renal significance, and it will be case-based discussion. So you can also be free to distribute your questions to the chat box, please, after the presentation. Thank you. So Nasiba, the floor there is yours, please.
Assalamu alaikum. Is it audible for everyone? Assalamu alaikum.
وعليكم السلام. بس شوية أرفع الصوت.
حاضر. Thank you, Dr. Sayya, for this introduction. I just want to extend my thanks for giving me this privilege to be here today and present this topic. So we will start, as we said, with case presentation. We have this 43 years old female who was diagnosed to have ulcerative colitis in 2009, and she has been off therapy since 2015. She was seen for infertility and was planned for IVF. And for that, basic investigations were sent, and she was then referred to nephrology clinic for deranged kidney function. On assessment, she was normotensive. Her creatinine was 106, and urine dipstick showed +2 protein, +2 blood, and +1 glucose. Protein creatinine ratio came back to be 282.65 milligram protein per millimole of creatinine. She had negative ANA, ANCA, and viral screen as well. And she underwent renal biopsy, which was done on the 26th of July 2023. And the official report was released as follows. It showed focal global glomerulosclerosis with mild interstitial fibrosis and tubular atrophy of 10%. Acute tubular injury with mild to moderate arteriosclerosis with no evidence of immune complex disease by immunofluorescence. The patient then was reviewed further and her labs were analyzed in further and subsequent visits to the OBD. She was found to have evidence of proximal RTA. She had hypokalemia of 3.1, acidosis with bicarbonate of 17, +1 glucosuria, uric acid of 0.11, and hypophosphatemia of 0.72. Hence, the workup for the cause of this proximal RTA was sent. She was found to have normal vitamin D and parathyroid hormone. She did not have any evidence to suggest or support Wilson's disease, and her glycosylated hemoglobin came back to be normal. To finish the workup, serum protein electrophoresis was sent, and it did not show any clear abnormal band. However, the serum-free light chain ratio was high of almost 88. She then underwent bone scan, MRI, and PET-CT, which all did not show any bony lytic lesions. In view of those findings, on 16th of August, the biopsy of her renal, the slides of her renal biopsy were again looked at. And it showed very mild lymphocytic infiltrates. It did not show any atypical lymphocyte or plasmacytic infiltrate. Congo red stain was used and it was negative for any evidence of amyloid. Immunofluorescence was reviewed and it showed no light chain restriction. Electron microscopy showed again no atypical or structured deposits seen. In view of that significant free light chain ratio, she had bone marrow biopsy done, and it showed increased monoclonal GABA restricted plasma cells, accounting for almost 10 to 15%. She did not have anemia. Her hemoglobin was 12.6, and she was a normocalcemic with calcium of 2.23 millimole per liter. Again, on 17th of September, and now in view of this collective evidence of Fanconi syndrome, coupled with the high kappa light chains in the serum and the plasma cells on the bone marrow biopsy, the slides were again looked at. The report came back as follows. So in the immunofluorescence for kappa and lambda, it was performed on the formalin fixed paraffin embedded tissue with Bronese digestion twice in our hospital, and both confirmed a preferential staining for kappa in tubular epithelial cell cytoplasm in comparison to lambda with granular pattern of staining. Unstained slides were sent also to Royal Hospital, and it confirmed the presence of kappa positive staining in tubular epithelial cells with negative staining for lambda. Another interesting finding was detected on electron microscopy, where it showed enlarged lysosomes with pleomorphic acellular structure in the superficial aspect of tubular epithelial cells and in the lumen that have a homogeneous texture representing non-crystalline form of light chain material. And we have asked our nephropathologist to be with us here, but due to other commitments, she could not. So I have here the slides of this patient. So with fresh, this is immunofluorescence of the fresh tissue. It did not show any restriction. However, when done to formalin fixed tissue, it showed significant restriction for kappa. And these are the structures that were seen in the electron microscopy, suggesting enlarged lysosomes. Now, all these findings are consistent with light chain proximal tubulopathy with kappa light chain restriction. And based on all of these findings, we conclude that this patient has monoclonal gammopathies, which is defined here as the presence of a monoclonal immunoglobulin in the serum or urine, or both, as a result of clonal proliferation of plasma cells or B lymphocytes. These gammopathies are leading to renal impairment in this patient. So the questions here are two. One, what is the underlying hematological condition here? And two, how should we manage this patient kidney disease? So if we look at the traditional classification system for monoclonal gammopathies, our patient does not really fit these disorders shown here. These disorders shown here are classified based on clones. Is it plasma cell or B cell? And based on tumor burden and how much of bone marrow is involved, how big is the M spike, and whether or not there is organ damage. So there are specific criteria to dictate whether or not clone-directed therapy should be initiated. Typically, the patient have to meet tumor burden criteria or have kidney or any other organ damage at the same time. For example, when we talk about multiple myeloma, we know that it needs at least minimal bone marrow involvement of 10% or M spike of more than 30 plus one or more of myeloma defining events. And that applies as well for CLL. For patients with smoldering multiple myeloma, for example, even though they do not meet tumor burden, they do not have organ damage. So we monitor these patients over time. For patients with MGUS, they do not need tumor burden criteria and they do not have organ damage. They will be again observed over time. Our patient does not meet the diagnostic criteria for any of these conditions. Therefore, the patient, based on this classification system, will not be classified for clone-directed therapy. Now, if you look at all patients with monoclonal immunoglobulin-associated renal diseases, most of these cases actually occurred in the absence of a hematological malignancy. And this is very interesting data published in the New England Journal of Medicine, where it showed that the majority of these patients, as illustrated here, anywhere from 40 to 96% of these patients, they do not have any concurrence with most malignancies that require treatment. So most of these patients were not actually treated. The only exception, of course, is AL amyloidosis, as obviously it has been a long recognized condition and has been associated with high mortality and morbidity. And we already have standardized treatment protocol in place for decades now, but the rest of those patients or people were not treated. Now, how did these patients behave without appropriate treatment? Actually, they did not do so well. So their disease usually is progressive with high rate of end-stage renal disease. And some patients were able to get kidney transplant after reaching end-stage renal disease. However, the recurrence rate in allograft or in the transplanted kidney were really, really high. There are reports of recurrence up to 90% in the first year following transplantation. These patients at higher risk of progression to hematological malignancy as well. And recent study showed that there is 10% risk of progression to multiple myeloma in the first year, where on the other hand, when we compare patients with MGUS, they have risk of 1% to progress to multiple myeloma in 1 year. So it's 10 times higher the risk. The diseases in this category are very poorly responsive to conventional immunosuppressive therapy, which have been tried previously to delay the progression. However, they failed to do so. And for the group of patients who were successfully given clone-directed therapy, it was noted that they reached complete renal remission or stabilization of renal function. Now, because of all of this, many in nephrology community and hematology and oncology community as well, they felt it was necessary to provide a better classification system to improve these patients and to discriminate them from MGUS population. So in 2012, the International Kidney and Monoclonal Gammopathy Research Group, they coined a new term of MGRS, to acknowledge the causal relationship between monoclonal proteins and renal disease, and also to increase the recognition of this group of patients. So MGRS applies to any B cell or plasma cell clonal lymphoproliferative with both of the followings. One, they need kidney lesions that are related to produce monoclonal proteins, meaning that you have to prove that the monoclonal protein is nephrotoxic and causing the damage that you see in the kidney. Two, the underlying B cell or plasma cell clone does not meet the current hematological criteria for therapy, which I have detailed previously. Now, the inclusion of MGRS in the new classification system is separate from MGUS, and it has been facilitated, it has facilitated the adaptation of clone-directed therapy in these patients, and of course, it has implications in coding and research purposes. So when we talk about MGRS, it basically encompasses a wide spectrum of complex and heterogeneous disorders as shown here in this slide. And these diseases have discrete mechanism, histopathology, as well as outcomes. These monoclonal proteins could be light chains like lambda or kappa in our patient, or it can be intact immunoglobulins or rarely free heavy chains. And now moving to classification. So MGRS is associated renal lesions can be classified in two ways. One is based on the location of the deposits and the site of renal injury. So most of MGRS lesions are located within the glomeruli. Very few are tubular in origin or tubular in nature. Some diseases can affect multiple lesion compartments, and the best example of that is AL amyloidosis. The site of monoclonal protein matters. For example, free light chain not only they can deposit in the glomeruli, but as they are smaller in size, they can filter freely and they can cause tubular injury. Again, best example is our patient here. Intact immunoglobulins are large, they do not get filtered through, and most of the damage is done to the glomeruli. Now, another way to classify MGRS is based on the presence or absence of monoclonal proteins on the kidney biopsy. So when we talk about C3 glomerulopathy and TMA, these two disorders do not actually have monoclonal deposits on the kidneys. The renal injury here is actually due to indirect mechanisms and as a result of monoclonal protein and activation of complement system. But if the monoclonal deposits are seen and present in the kidney, we then classify them as organized and non-organized based on the characteristics that are seen on electron microscopy. So non-organized means that the depositions looks like, or they look like anything. There is no specific pattern or structure to them. Examples of that are monoclonal immunoglobulin deposition disease and proliferative glomerulonephritis with monoclonal immunoglobulin deposits. When the deposits are more organized, there is distinct structure to them. And on electron microscopy, they can look like fibrin, microtubules, or inclusions and crystals. The list for that is long, and one of them is the light chain proximal tubulopathy, like in our patient. We will a little bit elaborate on the light chain proximal tubulopathy. So usually patients with this, they present with proteinuria with mild protein of 1.5 to 2.5 gram per day. They have mild CKD and proximal tubulopathy with or without the Fanconi anemia. Usually Fanconi syndrome, sorry, is the first clue, but it's not necessarily one of the diagnostic criteria. Light microscopy usually shows proximal tubular swelling, and in immunofluorescence, proximal tubular staining is illustrated with crystalline for kappa and non-crystalline for lambda. On electron microscopy, the proximal tubular crystals or lysosomal inclusion are seen exactly like in our patient. And the most common extrarenal manifestation in patients with light chain proximal tubulopathy is stress fractures, and it has been seen in 40% of all patients. Now, moving on to some epidemiology. How common is MGRS? Actually, the incidence and prevalence is not really known at this time. However, we have recent studies that one of them is published recently from China that looked at close to 700 patients with MGUS who underwent renal biopsy. And out of those patients, 38% of them turned out to be MGRS. Another study from Vanderbilt, which is in Tunisia, showed that out of 121 patients with MGUS who underwent, again, renal biopsy, 42% of those patients had MGRS. A study from Mayo Clinic showed, again, 40% of their patients had MGRS. So these numbers are quite impressive, and they actually unexpected to me. We always thought that this is a rare disease. However, these numbers emphasize that the importance of recognition of this entity, and we all need to be aware of it. As I said before, most patients will present with glomerular presentation indicated or evident by proteinuria within the nephrotic range syndrome or subnephrotic, sometimes hematuria and varying degree of renal insufficiency. Hypertension is quite common, although in amyloid patients, hypotension is more common. Edema can be seen in nephrotic syndrome patient or with advanced kidney disease. In tubular diseases, there is usually minimal proteinuria and evidence of Fanconi syndrome, and again, varying degree of renal insufficiency. And it's always important to look for the extrarenal manifestations because it can guide the diagnosis as well. Now, when we talk about the diagnosis, It's important to highlight what I have said before, that not all patients with MGUS and kidney disease equals MGRS. You need to be able to illustrate or demonstrate that nephrotoxicity is caused by that lesion detected on the biopsy. Definite diagnosis requires a kidney biopsy and a clinical pathological correlation. And that was very evident in our study because we went back to the renal biopsy 3 times to detect the abnormality. Early diagnosis is key, as eGFR at diagnosis is a major predictor of renal outcome in MGRS. So serum protein electrophoresis is the first thing we do. However, it will be unable to detect if the level is less than 0.3, which is usually the case in MGRS. So serum immunofixation is superior to that. However, serum free light chain is more sensitive, and definitely renal biopsy is the gold standard. A study from Mayo Clinic found that several clinical features can be strong predictors of finding MGRS lesion on biopsy. These include proteinuria of more than 1.5 gram per day, hematuria, and abnormal free light chain ratio. So if you have a patient with these clinical features, it's really important to evaluate this patient and to pursue renal biopsy. And this basically summarizes what we have just said. Now, as you can see that the care of patients with MGRS requires multidisciplinary approach with close collaboration between nephropathologists, nephrology, and hemato-oncologists. So back to the case, we got a patient with MGRS who was referred to hematology for further evaluation. However, you as nephrologist and me as a resident rotating in nephrology block or rotation, we should be able to manage, or we will be managing this patient disease in regards to all aspects, in regards to volume status, measures that can reduce proteinuria, blood pressure control, if they developed CKD, and their management like anemia or bone mineral disease as well. However, what will be the specific approach or treatment for these patients? Usually the treatment strategies are based on chemotherapy. These are based on chemotherapy that must be adapted to the nature of the cell clone, both lymphocytes and plasma cells, and to the kidney function as well in the presence or absence of extrarenal involvement. However, the main combination includes proteasomab, cyclophosphamide, and dexamethasone. This followed by allogenic stem cell transplantation. And this was actually what was offered to our patients after the diagnosis was made. However, she declined therapy and she preferred to go abroad for second opinion and for repeat of renal biopsy. Thank you for listening. If you have any questions, I would love to answer them.